Next, we will have a lecture by Dr. Vishnu Kumar Patra. So, he is a professor, HOD of the Department of Orthopedics at AIIMS Bhubaneswar. So, he is a senior orthopedic surgeon who has been involved in this field of regenerative medicine for the past few years. He has done a lot of cases with both autologous as well as allogenic stem cells. Today, he is going to present about how you can take a biopsy from the bone or cartilage, send it to a company. That company will culture the cells and then send it back to us. So this sort of autologous cultured stem cell therapy is available in India through a company which is approved. So this is an approved way of treating the patient by the government of India. So he is going to present about this regrow. Over to you, sir.
Good morning all. Myself, sir is already introduced, so I will be speaking on autologous cultured osteocytes or osteoblasts. At the outset, I like to thank Ravi sir and all the organizing team who have invited. This is the first time visiting your city, such a beautiful city, and also saw the Rockford Temple. And thank you very much for the invitation. So to start with, what is avascular necrosis of the femoral head? It is something where you find less blood supply to a particular bone, there cause necrosis. As it is due to less blood supply, it is called as avascular. So there are many areas, but my topic will be pertaining to the head of the femur. This osteonecrosis is also used interchangeably along with avascular necrosis. As you know that any treatment goes by the staging procedure. In what stage of the disease you are presently, because the stage could be 1, 2, 3, 4, and the management is different for different stages. The management for stage 1 is completely different for management of stage 4. This particular procedure is restricted to stage 1 and stage 2. It has been tried in stage 3, but it has failed terribly. And 4, it should not be tried. Then the subchondral cyst or the necrosis or the crescent sign, which comes as a 2A or 2B, this is the point up to which you can use this procedure. There is staging, but each staging is different. Like if you ask the same X-ray or same MRI in different dates, you may give a different stage because there are a lot of inter and interpersonal classification. And one study said that there is significant intra and inter observation variation by FICAT and ARCO classifications. So today what you say the X-ray is 2, tomorrow or maybe after 10 days you may forget and may say it's 3 because this is little bit confusing. And what are the causes? Diagnosis. These patients are diagnosed by high suspicion because by the time they go to stage 3 and 4, it is very evident. But for the stage 1 and 2, the diagnosis is very much suspicious. If they complain of something, the diagnosis should be done. And the history, like someone who is addicted to alcohol or has some medicaments due to some conditions, a lot of steroids, and also there are some protein powders here in the market they use for bodybuilding. And if it is from a sickle cell zone, all these cases, and nowadays you may be showing that post-COVID there are a lot of conditions and post-irradiation for different cancer conditions. So in these patients and the patient complain of pain in the hip, there should be high suspicion that this patient might be having a early avascular necrosis of the femoral head. So this is how a X-ray looks like. A patient who is just complained of groin pain, what the orthopedist do is, okay, take some medicines or some paracetamol, aceclofenac and leave it. But this particular patient, I did the same thing, but when the patient complained the same pain after 3 weeks, I just asked for a X-ray and MRI, it is already in stage 2. Just imagine if this patient would have not been done an X-ray, very soon this patient will go to stage 3 where your cells will not work, will end up with using or hip replacement. So high degree of suspicion for these patients is very, very important. And these are the routine diagnosis managements for these patients. Then 2 X-rays, AP and frog lateral. The frog lateral view of the hip joint is very essential for diagnosis. They are more sensitive than your true AP views. The frog lateral view has a higher sensitivity and accuracy than anteroposterior views. There are people who have done that. They have done AP views and true lateral and frog lateral, and they found that the disease could be better diagnosed with a frog lateral view. And it is very simple. If you just advise AP and frog lateral, the radiologist will do it. There is nothing too much of science in this. MRI is the diagnosis of choice, and in India it's very much available everywhere. So there should be no hesitations. If you have any suspicions clinically or anything like in the X-ray, we go for a MRI. Strong evidence of high degree of efficacy of SPECT CT in the evaluation of AVN femoral head. The SPECT can help, but I don't think it is too much required because MRI is more than enough. And one more thing is in that if the necrotic area is less than 33%, the chance of progression of disease is less. So, and also the collapse is when the corbal angle is less, the chance of progression is also less. Now comes the management. See, the stem cells came to the market for last couple of years, maybe 2012, as of my knowledge. And I started in from 2014 because I also took 2 years to understand what is this. And PRP I just started 3 years back, or may not be 3 years, 2.5 years. So before that something was going on, and there were also some methods. So restricted weight bearing, because you know that when something is collapsing, the best thing is to sleep and don't bear weight, because this ball head of the femur is circular, will flatten. But it is not enough in single. Then bisphosphonates, it has been used before and also today. There are many centers because all doesn't have access to these stem cells. So they are still using bisphosphonates, and there is also some results in stage 1 and 2. They have also got some good results and good papers, but in single, they are not sufficient enough. Anticoagulants, extracorporeal therapies, hyperbaric oxygen. I am listening from my PG days that this is under study, and till today this is under study only. I don't know what is the future of this, all these procedures. Because when I'm the first year PG, I have the same slide, and when I'm the professor at the department, I have the same slide, that these 3 things are under study. So I don't think any future of this particular medicaments. Then code decompression is a very valid process, and it works in stage 1. And even we are doing, as of now, even of the stem cell also, the stem cell are given after only code decompression. So code decompression is the center of that management. After that you can inject whatever you like according to choice. Efficacy of orthobolic adjuvant to code decompression for hip reversion in avascular necrosis, they found that CD with BMAC works more efficiently than only code decompression. So if you are only decompressing, it is going to have inferior results. So fibular grafting, you know that fibula bone is called the wonder bone. Wherever you don't find any defects, you can put this. This fibular bone can be used as a vascular graft or a avascular graft also. But vascular graft is more by the plastic surgeons, and it also works wonder. But many thing problem is that it's a very long surgery and takes almost 6 to 7 hours if it's a vascular surgery. If it's just a non-vascular, then you can end up in just 1 hour. But the results are not predictable always. So osteotomies for osteonecrosis of the femoral head has been tried to derotate the head of the femur so that weight bearing area doesn't come on the necrotic part. But still it is not that effective. I don't really advocate this particular procedure. Vascularized fibular graft, as I already said this, the preferred treatment of the hour. As of now, if anything happens, this patient in stage 1 and 2, my preferred choice will be code decompression and cultured osteoblast transplantations. That is autologous. And the literature says that osteochondral transplantation has a great potential in healing of avascular necrosis, and so many will find 100 literatures, all are supporting. Even recently we have also published our paper in the Indian Journal of Orthopedics, our results, and it is very much encouraging. The most recent advances are stem cell enhanced code decompression. So see that everybody is focusing on these autologous cells. Now these cells you can get, people are also trying for this homologous also, but I don't know how far they have gone. But autologous cultured one is really fantastic, and many people also tried concentrated, that also you can try. So this is effective in stage 1 and 2. Predictable and measurable parameters, better patient compliance and result satisfactory. Because at the beginning I had extended my indication to stage 3 also, but after knowing it I have shut down for stage 3 only stage 1 and 2. So these are the steps. What you need not to do that, the guide wire should not penetrate the cartilage, and you should have a proper decompression of the dead bones, and many times slow injections, like you have to give the cells very slowly so they do not wash out back, and there are the intraoperative procedures. So these are the few steps, like you have to harvest from the posterior superior iliac spine or the anterior superior iliac spine, wherever you are preferred. Then you harvest it, send it to the lab. They will come to you after 1 month. So 1 month you should be ready with the patient, then do the core decompression, curate the dead bones, and inject this particular cells. That cells is around 40 million cells per one femur. So this is a one patient. She is working in new media, and she had complained, and what you suspect is she will progress to hip replacement if you don't act in the right time. So what you find, after treatment, at just 6 months, she's feeling better. She could squat, she could sit cross-leg, and a proper walking. This is another patient with similar bilateral AVN, and you can see that this particular MRIs, the X-rays may not be very much pretty good, but this MRIs, you can find that the disease is very advanced stage 2. And this patient also did very well, and you see that the head is well managed and still circle, there is no flattening or any compression of the head, and it is managed the same manage of cells. This one patient is a very interesting patient I like to share with you. See, this side will never dare to do a core decompression and culture osteocytes, and this one, so I tried this one with cells, this one with total hip replacement. Fine, this patient was doing good. Next, he was posted in Sikkim, so where it was very hilly area, he has to do lot of climbing and lot of hard work. So he didn't had proper restriction, so later on he also had stage 3 of the side which I have injected. Now this patient has to go for hip replacement the other side. Yes, we can do it, but it should not be the first choice, because if it works, out of 10, at least 8 will work if your diagnosis is proper. So this patient, we have to later go for hip replacement bilateral. He is fine, he is walking there, but only thing is that he had to spend some money for the preliminary surgery. This is another patient, he is a medical student. He is studying in AIIMS Raipur. So his father forced me to do this regrow or this culture osteocytes, though it was stage 3. I refused, but he said, okay, let the money goes, I will try. Then I realized that it didn't work. It didn't work, and he is still going his studies. Maybe very soon he is going to go for a hip replacement. So this stage 3, my observation is we should not go for stage 3, we should restrict to stage 1 and 2. This is another patient who has similar affection, and after 2 years of the therapy, you will not find what is the results. There is no deficit from the patient. He can walk properly. He is a techie walking in Bangalore, and he is just some 28 or 29 years, and he can sit, he can squat, like everything normal. So this procedure has a very advantageous procedure, and mostly what you find is in my patients, see the age of this patient, 27 years, 23 years, 24 years, 27 years. What I want to present here is all these patients are in their active stage of sex life. So which is very important. Just imagine a daughter is married to his son, and the son is diagnosed with this before being any kids. I got the call from the parents rather than the patient himself. Okay, what will be their sex life, whether they can bear child or not. And this is very important. See, my patient, all are in this before 30 or 35 years. That was most important. But if you are going for a hip replacement, we cannot give the same type of sex life what they desire. But if you can retain the head of the femur, they will have a very normal life. Out of them, 3 have got married and also kids by now, because it's a 5-year follow-up as of today. So all these persons, they can ride scooty, they can sit, then squat. The middle one is she's walking in Paris in fashion designing, and the last one is a teacher, and both these are techies, they up and down. So the sex life is, as I all explained, it should not be ignored. So to take home message is, there should be the diagnosis should be high degree of suspicion. If anybody is complaining of groin pain, you can give a 3 to 4 days of medication, but if still continuing, you should go for X-ray, and frog lateral is very important, and you must do that. MRI is diagnostic, And second opinion is must for final staging. If you are having doubt in the staging the disease like 2B or 3, then you can take help of a colleague. And this works. As of today, I started in 2014, this particular procedure works. So it is up to you how early you adopt it, but my request will be, you have to choose at which year what you want. The same disease at 15 years or 85 years, we cannot have the same disease. At the earlier age, you can go for later this one for hip replacement because you know that the life existing is just 10-15 years. But these patients, we cannot afford to go for a hip replacement. With that, thank you very much, and thank you Ravi sir once again for your invitation.
So few questions. Chandru, any questions?
Sir, when do you allow weight bearing, sir?
Sir, my weight bearing allow is unilateral, bilateral is different. For bilateral, completely 6 weeks bed rest, not even standing also. For unilateral, they can walk with crutch walking with one leg. But for 6 weeks, no toe touch, absolutely no toe touch.
And
So the same question was asked in the previous conference. They said that we are getting poor results. I said you have to increase your weight protection. At least you should give protection up to 6 weeks. But they are allowing weight bearing within 7 days, which is I feel is not appropriate. My results maybe this is the good reason why I am giving, because all are using the same company and same cell, 40 million cells. But my results I can attribute to the proper staging and proper weight bearing protocol.
do you allow squatting, sir? Squat.
After squatting, after maybe 5-6 months, not now, before. Weight bearing after 1.5 months with partial weight bearing, 3 months complete weight bearing allowed, squatting and all the stuff after 5-6 months.
Thank you, sir.
It's a great presentation.
Thank you,
Enjoyed
sir.
it. Just a couple of questions.
Sir.
It could be very naive. Just maybe I missed it. How many million cells the osteoblast?
Sir,
The transplantation of
Yeah.
osteoblast. How many million cells?
40 million cells
40 million. And
for one hip.
what about the prognosis? How long does it take to see any improvement?
Sir?
After the injection. After the injection, how long does it take?
Sir, I have follow-up of 6.5 years. My first case was in 2017.
Okay.
So I have done more than 40 cases of this. 2 have failed, sir. I have shown both the 2 cases which have failed. One is because of extreme pressure, he was walking in hilly area. I said one THR, other side regrow. The regrow also failed up to 2 years. And the other one is the bilateral stage 3. I was forced to do because he was a doctor, but that also failed. Now up to stage 2, sir, I am getting pretty good result, and one of them is my brother's son-in-law. So I have direct touch with him, so I get the information every day.
Excellent. But in your last slide, you mentioned that's your preferred choice
Yes, sir.
when it comes to treatment.
Yes, sir.
And just another question, again, it could be naive. In your first or second slide, when you spoke about the treatment, you mentioned about the anticoagulant.
Yes, sir.
And also the statin. I'm intrigued by that.
Sir,
So,
I said
see,
no, those slides are from the very my PG days, that is under study only. I have not used it because they say that is due to coagulopathy and vascular. So statins might be working. But it is still in the, sir, only few literature you should find hyperbaric oxygen, statins, and I have not used, sir.
Thank you.
Sir,
Thank you so
sir.
much.
Thank you.
Thank
sir.
you so much, sir.
Good morning, sir.
Thank you, Dr. Patra.
Sir, just here.
Yeah.
Good morning, sir. It's a nice presentation. I'm Dr. Manohar from Salem, sir.
Thank you, sir.
Sir, I want to know the follow-up of your cases. I mean, follow-up, not only clinical, sir. Radiological, when will you plan?
Sir, radiological, this is very important question, sir. You can do the X-rays, but don't do the MRI before 2 years. You will be more disheartening, and most important, the patient will say that the same lesion is still there at 1 year, 1 and 5 years. So don't do the MRI at 2 years. Only do the frog lateral view at the X-rays, and I do at post-op immediately to know how I've done the operation. Then at 3, 6, 12, and every year.
And you will see the non-progression of the disease.
No, you will see the flattening of the head. If it is not working, there will be flattening of the head of the femur.
Okay.
And that will be more visible in a frog lateral view, sir,
Okay, sir.
rather than AP view.
Sir, have you tried any autogenic BMAC?
Cultured, I have tried, but BMAX, what is that? Concentrated BMAC I have
Yes.
used,
Okay.
and but there's only one case because he could not afford the price, and that
Okay.
is in maybe 4-5 months follow.
Okay. In that case, how, volume, what volume you have given, sir?
Sir, it is not possible to give more than 1.5 ml because
Okay.
beyond that it will backflow.
Yes,
And
sir.
I used to
How will you
use
prevent?
bone wax to pack
Bone
it.
wax.
So it's a very, I don't prefer, sir, only because he could not afford very poor patient. So as I said, core decompression also works in stage 1. So this is an addition. Maybe it will be working. So I'm not sure. I may be answered at 2 years follow.
But curettage, you say it's very mandatory.
So curate is mandatory and you take out the dead bones also. And I also do the histopathology of all the necrotic bones what I harvest to send to the pathology. And at the end I found that they're just saying that bony trabeculus, dead cells, all the, and they could not differentiate. Like my opinion was to whether the necrosis due to sickle cell, due to alcohol, due to steroid are different or same. But I did not find anything different.
Okay. Thank you, sir.
Thank you, sir.
Thank you, sir. If we are just moving on to the next session.
Thank you.
Thank you, sir.